coming up next, we are really, really fortunate to have one of the global leaders in supply chain and someone who understands it at a root level better than probably most, certainly on the global public health side, and very happy to bring on a leader from the United Nations in this area, and looking forward to hearing and talking to him. So for those of you who are just joining us as well, we've been online now for about 24 hours a day over the last couple of days. This is day 3, and we are moving forward here today with an exciting agenda. We've got an extraordinary group of presenters, including just coming up now at the top of the 9 o'clock hour, Andrew Williams, who's going to be talking about remote surgery in crisis. And then following Andy, we're going to have Donato Tramuto talking about compassionate leadership in his recent book, Compassionate Leadership in Healthcare and the Effects of Social Determinants of Health, which couldn't be more timely when we talk about what's going on right now in healthcare, especially for really understanding patients and the people that are serving patients today. It's really critical that we have that kind of essence to it. And so today with us, we have 2 spectacular speakers joining up now, and we'll kick off by having them do a brief background on themselves, and then we'll dive into some really critical questions here about how the public healthcare system in the US and abroad is facing this pandemic and this endemic. And Nadine, if you could start, that would be wonderful.
Thank you. Thank you so much for inviting me. It's great to be here, and it's great to be sharing the panel with Andy Williams, who I had the pleasure of meeting last night and was incredibly inspired by the work that he's doing. My name is Nadine Harim. I'm a surgeon by background. I trained in reconstructive plastic surgery, mostly in the areas of breast and pelvic cancer. But as a surgeon, having grown up in many parts of the world, it was clear to me in my experience at the front line, I guess, in clinical practice, just the sheer fundamental challenges that we have in surgical care. And I saw that through a number of different lenses. I was very involved in our own clinical practice, but I was also involved in global health. So for about 10 years, I was traveling to many parts of the world to look at capacity building efforts and sustainability in surgical care. And it was clear to me after a number of years that we are limited in the fact that surgery has historically and still continues to rely on physical co-presence. We're also limited in that there's a huge amount of opacity in terms of information, what's happening in that OR, and how are we learning and crowdsourcing knowledge from those environments and redistributing them to where they need to be. This concept of a one-to-many and many-to-one. If I'm a clinician and I could virtually reach in to any operating room around the world and learn and share best practices and gain insights into how surgeries are happening in other parts of the world, that I could perhaps play a role either as a learner or a provider of expertise, couldn't we really accelerate surgical care and reduce the high amount of variation that we have? At the same time, there's incredible care happening all around the world in certain parts, and how could we crowdsource that knowledge and redistribute it? And there wasn't really a solution on the market at the time. And so as a stubborn clinician, I wanted to, if there wasn't going to be one available, I was going to create it myself. And so designed Proximy, which is a software solution that enables you to connect and collaborate operating rooms all around the world and drive a cohesive data environment for learning and best practices. And it's been the honor of my life really to have been able to create this and deliver this to so many operating rooms around the world, to enable doctors to deliver the care that their patients need closer to home, closer to family, closer to support, and to provide the coaching and mentoring that sometimes as clinicians we need when we're in those difficult cases, and having someone there as an extra pair of eyes and an extra, support structure is key. And we've been used across the world in over 60 countries, in over 500-600 hospitals, and have been also, supporting public sector military efforts in the field, as well as great global health initiatives in Kenya and other parts of the world. So it's truly an honor to be here and to share the panel.
Well, that's wonderful, and thank you also as a longtime member of the Royal Society of Medicine. Thank you for your work and your leadership with the RSM. It's been a while since I've been on Wimpole Place, but I do look forward to getting back there as soon as I can.
It's still there.
It's still there. Well, I imagine it would be after hundreds of years of residence there. And Andy, again, really appreciate you joining. I know how absolutely swamped your schedule is these days. And again, incredible background like Nadine. You're all over the world. You're doing incredible work with the United Nations. If you could give the audience, and again, we've got a global audience here of people all over the world watching right now, a little bit of your background, and not only a little bit of your history, but also what you do today for the UN in helping to really combat the pandemic and mitigate its effects.
Hi, Stan. Thanks very much for inviting me again. It's a real pleasure to be here again, to be able to speak to people all over the world. My name is Andy Williams. I'm actually an officer in the Australian Army, and I've been seconded to the UN. The chief medical logistician at the UN is a military position, because a great deal of the work that we do is related to peacekeeping operations. The UN is currently running a number of peacekeeping operations in the world. There are 13 major operations with about 100,000 UN personnel deployed, a mixture of UN civilians, police, military personnel, and locally engaged staff as well. In addition to that, I provide the support to all the UN country offices around the world. We operate currently in 183 out of 193 countries. And in terms of providing any kind of medical support or medical logistics, that falls to me. Obviously, the last 2 years has been interesting, to say the least, trying to secure the additional resources that we need, both for our peacekeeping operations for COVID patients, to evacuate them to both treat them in the peacekeeping operations, to evacuate them out to a number of centres of excellence that we've contracted with around the world. And then to put in place the aeromedical evacuation system to make that work. So I'm involved in all of those things. And then more recently, we've been involved in vaccinating the entire UN family of agencies and their both staff and their dependents. So about 1.6 million people, again, in about 100 countries around the world. So very busy at the moment. A few crises coming up, just to put a little bit more pressure on me. I know Nadine will be interested. I'm currently very interested in what's going on in Lebanon, supporting them there, and then also Ethiopia. That's the other thing that's come on my table in the last few days. So that's me. My interest here, I'm really, rather than being at the technical side of this, I'm more at what I would call perhaps that operational side of trying to deliver clinical effect all around the world in a number of pretty remote and austere places, where for a number of reasons we want to keep the number of people on the ground to the minimum number. So we don't want to have a large number of clinical staff in the ground if we can avoid that. And so what I'm trying to do is bring what I would call sort of the clinical intellect to the point of care, to provide the best possible care for our peacekeepers wherever they are, and then increasingly to provide some equity for the peacekeepers who may become injured after they finish from the peacekeeping missions. We have a range of sort of issues there. Most peacekeepers come from sort of middle income and developing nations, places like India and Pakistan, Bangladesh. They're amongst our biggest providers. We have a small number from highly developed countries, and then we have some of the local staff who might be in some of the most sort of austere and poor health systems in the world. And we feel we have the moral duty to try and actually provide a standard of care to all of them, particularly if they have any kind of injury or illness resulting from their service in the UN. So again, my interest is in how I can facilitate that, to bring the expertise that our first world contributors have to those who are in the most pressing and difficult circumstances. So that's me. Stan, you're muted.
I've got a barking dog in the background working from home here, so I do mute myself occasionally. So yeah, that's a great background, and again, I really appreciate the detail there, and both you and Nadine, again, thank you guys for your service. You're on the front lines of doing this. I can't imagine the horrendous hours and pressure that you must be under right now, especially with Omicron coming out and making things, again, just absolutely desperately bad for so many folks around the world. And so if we could, Nadine, if you could talk a little bit more about, certainly what the topic title is for this session, which is, really understanding this kind of this nuance of remote surgery and trying to bring these technologies, again, they're highly emerging technologies. And the next guest is going to be Donato Tramuto, who founded something called Healthy Villages with Kerry Kennedy, and has done an amazing amount of work of sharing digital technologies in sub-Saharan African countries to help improve medical care, as simple as like iPads and some various tools to villages that are 1 or 2 days from hospitals, so that physicians who've never been trained in a certain type of surgery can learn how to do surgeries with surgeons, from some of the world's best hospitals in either London or Boston, New York, San Francisco, et cetera. And so the idea is that, Nadine, tell us a little bit more about what this means to you and how you've seen this evolve rapidly, I'm sure, because these sorts of technologies have evolved more rapidly than ever before over the last 2 years as a matter of need and consequence. What have you seen in remote surgery develop over the pandemic that you think offers the most hope over this new endemic that we're in the midst of?
I think it's a really good question. And perhaps also for the audience, the way when I think about remote surgery, and I imagine how others would perceive that statement, it very much is still perceived as a moment in time. I'm going to dial in and I'm just going to be there for that one case. And the way we look at surgery, and I'm sure Andy would agree, we were having this kind of great discussion about this last night, is surgery is a continuum. Surgical care is a continuum that it stems much more than what we have historically been using, which is see one, do one, teach one. That's been the mantra that we have been looking at in surgery. That's how we were trained. But we need to change that. We need it to be, rather than 3 points in your journey, actually a continued experience of prepare, perform, and perfect. And so when we think about an operation, it's not just about that moment in time. It's how did the teams prepare for that? How were the teams upskilled to deliver that care? On the day of the case, were they supported? Was there any proctorship or coaching that was happening during the case to enable them to deliver care? And then after the case, has it been recorded? Are we able to go back and review performance and debrief? In the same way as you would think of the game tape in athletics or sports or the aviation industry. And that's a big mind shift that we need to think through. But what it means is that you now are really thinking holistically about workforce and how do you improve the availability and accessibility of skilled workforce to deliver care to patients. And I would caveat everything by saying it doesn't have to be a doctor. I mean, in some areas, the most skilled person could be the local nurse or the local healthcare worker. The key, though, is that they are provided with the right support infrastructure, the right tools and the right mechanisms that enables us to democratize that access to care. So that's what I would sort of say at a high level. But when I was thinking about Proximie, the things that were running through my head was, how do we make this accessible, affordable, and scalable? And these are cliche words perhaps in and of themselves, but at the heart of it is actually like in an execution format, how do you do it? Well, we needed to make sure that we were a software approach, because by focusing on software and being able to integrate with any device or any system people have, then automatically you've removed that kind of inequity that might happen if people can't afford a fancy HoloLens or a fancy sort of piece of kit. Proximie can be deployed on any hardware, whether it's your own smartphone or your own device, your own laptop. And it doesn't matter how new or cutting edge it is. It just needs to be able to run sort of a Chrome system. So that was one of the thinking behind the design. The second was about bandwidth. We can't ignore the fact that even within UK hospitals where I work and US hospitals, and I'm sure it's the same in other parts of the world, internet connectivity can vary. So how do you build something that is available and accessible in a seamless experience within those environments? And then finally is about sort of the scales. How can you deploy this remotely so anyone can have access to it? So those were the kind of the thesis, the way we went about thinking about purposeful design. And then it's about, at the end of the day, why we created Proximie in the first place and why we believe virtual collaboration, or kind of as we call remote surgery, is essential. It's because you want to make impact in delivering care to patients. And what I would like to perhaps share with you is a story, because often I think with a clinical example or a story, you can really see the possibilities here. And we have numerous stories on a weekly basis. We talk about Proximie's mission and vision and how remote surgery is changing people's lives. But this was a story of a couple of years ago, a 57-year-old lady who had a really, really complicated abdominal fistula. She was in and out of hospital for years in intensive care. She was being fed by tubes, and she almost died a couple of times. And it was really harrowing for her and for the family. I mean, eventually it all healed, but she was left with is a really awful hernia. So anytime she would cough or move or get up, this whole thing would bulge and she'd be in and out of hospital with pain and discomfort. It was really just a terrible quality of life. Now, she was in Lebanon. They have fantastic doctors, but this specific case was quite complicated. And so even the doctor was saying, look, do you want to fly overseas to where, they do this regularly every week? And she turned to us and said, I want to stay close to home. I don't want to leave. I want to be around my family, but I'd love to have this expertise provided for me locally. And so we got the experts to dial in and work with her local team. So the benefits were she stayed home and close to her family. It was more cost effective for her. Her local team were upskilled and supported through that case. So hopefully if they get another case in future, they're more comfortable doing it. And she had a great outcome. She went home at day 5 and the next summer she was living her best life. And believe it or not, that patient was my mother. And so you can see the kind of the possibilities and the opportunities it opens up, but one that me as a clinician, I'm very willing to sort of back because I've been willing to put my own mother through it as well.
And I think we've got some questions coming in from the galley. So, Andy, we've got one coming in for you around managing concerns of vaccinations amongst even the staff within the UN agencies. And I think that's a big one, obviously. What has been the most critical trouble during this pandemic for UN officers, and how are you trying to solve it? Again, great question from, from Jorge. But yeah, Andy, if you could address that and talk a little bit about that, and certainly some of the digital tools that the UN is utilizing to work with that.
So the biggest problem we had with vaccination initially was we had to we very much had at the front of our minds the logistics necessary to support the various vaccines which were coming along. And so for us, of those vaccines that first appeared, the AstraZeneca one appeared to be the one which had greatest utility for us because it didn't need the ultra cold storage. Obviously, very soon after the AstraZeneca came on the market, we then had this issue of some question over its efficacy and some of the issues of the potential side effects. And that led to some quite strong resistance from some of our staff who basically felt that they would prefer to wait until one of the other vaccines, such as the Pfizer vaccine, became more widely available. So there was actually a lot of work which went into sort of reassuring the staff that this was an effective vaccine. There was a lot of work done in terms of providing education, both directly through our health professionals and through the production of a number of videos and training and sort of information materials. So those kind of standard public health things, we did a lot of work in there. But we did reassure the staff that we would, because of that resistance, move over to one of the other vaccines as soon as possible. Obviously, one of the things that we have to consider is we are not sort of an occupying force. When we are in another country, we have to comply with the host nation's requirements. And again, we had issues where some of the host nations had concerns about the vaccine we're using, particularly if we were using it on local staff. One of the other things that the Secretary General made early on was a decision, again, which had to be very carefully explained to the staff, which was, we as the UN should not be seen to be special. So if, for example, a vaccination program was, or we believe there was an efficient vaccination program going to be offered in one of our host nations, but that might be delivered 3, 5, 6 months after we could deliver the vaccine, the decision was made that we would leave it to the host nation to deliver that, because of our sort of desire, our need to actually not be seen as this kind of specialist privilege organization which got treated before the local population. In terms of the digital thing, because we have a population all over the world, it's very difficult for us to track who's been vaccinated, what they've been vaccinated with and when. And so actually we did actually have to go out and buy some software to help us manage that. That created some problems for us, because you would think in a multinational organization with 7 official languages and 183 countries, we would have thought about the fact not everybody speaks English as their first language. And the system we had was in English. And sometimes it was both a question of people not being able to speak the language, or just the language that was used was a particular kind of medical language, or computer technical language that many people were not familiar with. So we had some teething problems with that, but we've worked through those, and we've now managed to vaccinate most of our staff around the world. Those who haven't been vaccinated, I'm afraid, are those who probably are never going to be vaccinated.
Yeah, that's a tough spot to be in as well, for sure, no doubt about it. And again, I think, when we talk about the work that you're doing, Nadine, within the UK, how are you seeing some other digital health technologies being adopted in the NHS that maybe were not being adopted in the 2019 era? Which technologies? In the US, we're seeing a lot of devices in the home. We're seeing a lot more telemedicine. It's being reimbursed at rates we've never seen before. Do you see that in the US, the UK as well? Obviously, you have a national EHR, something that the US is still striving for. But what are you seeing there?
I think you're spot on. I think we were definitely, I think a lot of centers, and, digital transformation is a term that we use quite broadly. And, there's elements of digital transformation that were happening more around the EHR, EMR side of things. And other points where centers were kind of paying homage to it, but weren't really sort of digging deep into sort of these digital solutions at pace. Naturally, COVID really highlighted the significant gaps we have in that kind of traditional bricks and mortar types of healthcare delivery. And also how trying to think about decentralizing expertise and care, diagnostics, monitoring, you name it, more closer to communities, closer to patients' homes, even within the home, was really going to be the path forward, because we can't continue delivering care the way we have from a GDP perspective, from just a resource perspective. We have to be thinking more laterally about how do we scale our workforce? How do we scale our diagnostic systems, our monitoring systems, our telemedicine systems? And so there was a huge acceleration in adoption of many such solutions, telemedicine being one of them, remote monitoring, peripheral kind of diagnostics, particularly around the imaging space, even applications that track kind of patients' reported outcomes and patients' experiences and patients' journeys, because those are so critical and so important. I think that has opened up a great opportunity. On the back end, of course, we continue to think about quality and value as opposed to the technology stack. It's, are these solutions actually solving a problem? And if they are, is it meaningful? And so that's a lot of the work that you're seeing happening at a more of a hospital level or a frontline level. We do have some central decisions being made centrally, but generally, England's big, and different catchment areas will have different patient population dynamics and patient population health. And so they're also trying to take a bit of autonomy and decision-making at a kind of local level. But I've been really excited because I lead innovation in our hospital. And so being at the forefront of seeing that acceleration of adoption has been very inspiring. And I hope, and I'm pretty confident that that will continue. That's not going to change back to the way it was.
Brilliant. And we have, yeah, go ahead, Andy, were you going to jump in?
I was just going to say, one of the things we did in the UN was our initial sort of a model of care was that as many people as possible would be looked after at home. So we actually developed a sort of a home care package, which included some basic monitoring equipment, oxygen concentrator, and all the sort of standard PPE that the family might require, and then be able to try and link that back to the medical officers, the doctors who actually work in our missions. In the end, the only way we could do that quickly was just use a mobile phone and just get them to call every few hours and just give an update on how the person was progressing. One of the problems, though, we found at the start of that was maybe a perception that this was an attempt to do care on the cheap, which it wasn't. I mean, again, we had to explain very definitely that we anticipated that our hospitals, not just our peacekeeping hospitals, but the hospitals in the countries where where the host nation countries would very quickly become overwhelmed, and that really we should avoid having patients in hospital who didn't need to be there. But at the same time, we wanted to reassure them that we were properly monitoring them and that the health professionals could intervene at the right moment should they begin to deteriorate. So there was a technical side to it and a sort of human side to that we had to tackle.
That's incredible. Yeah, and it really is something that I think we're seeing the consequence of is the human side. And you bring that up very, very astutely. I think, it's just, we're seeing, around the world now, the great resignation of so many people, and it's really affecting healthcare. The clinical extenders, the nurses, the physicians who are on the front lines are battling just unprecedented stress. And that's another good question coming in here as well, from someone on the West Coast of the US, who is asking, collaboration in a crisis. In terms of, what is the welcomed practice? What is the industry practice in the operating room? And then Nadine, if you can take this, for product delivery in restricted zones and providing product specific knowledge and expertise. How do you do that when you're collaborating with a crisis and you've got different operating room, product delivery and restricted zone knowledge expertise that's coming across? How is that managed in a pandemic era, endemic era like this?
It's a great question. I hope I've understood it correctly. I'll take a stab at it, and then you can let me know if Karen, if you want me to, if that's landing with your question. I mean, from our perspective, that's why it was really important that this was a software play, because it's really important. I mean, we don't want to be shipping equipment left and right. I mean, what we want is that people are enabling the tools and devices that they have. I think what you're alluding to is the heterogeneity in operating room environments. This is very common. That heterogeneity and that diversity exists everywhere, in the most cutting edge of hospitals into the most austere of environments. And when I mean austere, I mean, war zone Gaza, I mean, in the field in Mali, I mean, proper, systems where you're not going to be deploying any equipment. But what you know is that simply by opening your phone, that on a secure HIPAA and GDPR platform, you're able to connect and bring expertise in. And that seamlessness of an experience and being able to access that support, I think is one of the key elements in terms of how do you overcome industry representation and others. We are agnostic. We do not have any exclusive relationships with any industry players, and we have not to date for this reason. It's about being that middleware, that OS system that anyone can use in any environment that is bringing value. And in terms of unwelcome practices, I mean, it's really important to recognize that this is not, hello, I'm Western doctor coming to help so-and-so center. It's very much about the reciprocity of learning. I can tell you in the 10 years that I traveled overseas, I learned as much from the countries and the cities that I went to do, to operate with, as I hope they did from me too. I may have even learned more from them than they did from me, but it's really about bringing together expertise. And one of the beautiful things about surgery is that surgery is a collaborative specialty. It's not it's about teams. We're comfortable in that environment. We like having discussions about our cases. We like people visiting our OR and talking to us about how they would do something versus how we would do it. So it's a natural behavior that we're just digitizing. We're not suddenly completely shifting the behavioral norms of surgery and surgical teams.
Yeah.
Can I just add in?
Yeah, please.
Sorry, I was going to say, I add in there, look, the main probably unwelcome practice, I would sort of echo what Nadine has just said there. One of the things that you learn when you work in a multinational environment is that medicine and healthcare is practiced in very different ways in different countries. And actually, one thing is we all have something to learn from somebody else. One of the things that I've really learned while I've worked in the National Health Service, when I've worked with the UN, from when I worked in the British National Health Service or with the British military and Australian military, is there is a lot of stuff you really don't need. And you'll be surprised at how good a service you can deliver with a minimum amount of equipment if people who have an imaginative way of thinking. So the thing I would want from industry is not to be there to try and offer, our way or your way of doing it, particularly from a Western perspective. We don't really need that. We don't really need you to be on the hard sell. We don't really need that. What we do need, though, is your intellect about how we can look at a difficult situation where we have shortage of human, intellectual, and physical resources, and what can you bring to us in that operating theatre to close the gap between what is thought to be needed and what is actually needed to achieve the best outcome. So that's where I would see industry helping us, certainly in the UN.
Fantastic. for joining us today. We know that you're both very busy, and it's been a long year, a long week, and certainly a long day. So much appreciated. A loud virtual round of applause. Thank you, guys.